Well, good morning, everybody, and welcome to this very special event. We're delighted that you've joined us this morning to release this new report, the primary care and COVID-19. It's complicated, leveraging primary care, public health, and social assets. My name is Mark Del Monte. I am the Vice Chair of the Primary Care Collaborative Board of Directors, and I'm excited to moderate today's event. The Primary Care Collaborative is a nonprofit, multi-stakeholder organization that unifies and engages stakeholders across the diverse spectrum of healthcare. It promotes policies and shares best practices to support the growth of high-performing primary care. It's a membership organization of more than 60 organizations committed to its mission and to the shared principles of primary care that more than 350 organizations have signed on to. The PCC is dedicated to advancing an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. So as we get started this morning, the report itself is a PDF and it is available now. We'll put the link to the PCC website in the chat box. I hope you'll take some time to read it after this hour of introduction and analysis of it. It is a manageable size and contains extraordinary analysis. As we operate today, the lines will be automatically muted. If you have a question for our panelists and presenters, put that question in the chat box and we'll make sure that they will get answered after the panel has a brief discussion. This webinar is being recorded. The recording of it and the slides will be posted on the PCC website within 24 hours. Every year, the Primary Care Collaborative produces an in-depth report that analyzes a timely primary care topic and provides relevant data and evidence. This is the 10th annual evidence-based report produced by the PCC. There was no doubt that this year's report should be on COVID and primary care's role in this terrible pandemic. But the PCC also recognizes that health emergencies such as the pandemic require primary care to work more closely with other constituencies, and of course public health is at the top of that list. Add to this mix a renewed focus and commitment to health equity, which has unfortunately been exacerbated in this pandemic. And so this turns our attention to social vulnerabilities, or the social determinants or drivers of health, and the tools that communities have on hand to address these broad issues. So for this year's report, the PCC has examined primary care, public health, and the social assets all together to consider whether and how they mitigated the effects of the pandemic. These results are important to understand not only for the past, but also to help us prepare for future health emergencies. The report found, as you'll hear soon, that communities with strong primary care, strong public health infrastructure, and the fewest social vulnerabilities provided their residents much higher chance of surviving a COVID-19 infection and a somewhat better chance of not catching the virus. This report includes data at the county level before and after the vaccines were made available. This analysis helps us to support the case that primary care is vital and needs to be valued, and that we have devalued primary care to the peril of communities. The report findings also demonstrate that we need to invest more in public health, and last but not least, we need to work hard to close health equity gaps. So back to the report, we'll get a briefing on it and talk about it with a stellar lineup of experts. First, we'll hear from one of the report's authors who will walk us through the report. Then we'll get some analysis and application of the report's findings from a panel of experts from various fields. And we'll take a few minutes at the end for questions from the media and the audience. So let me begin by introducing Dr. Yalda Jabapur. She's a family physician in Washington, D.C. and medical director of the Robert Graham Center for Policy Studies. She has worked as a family physician in San Diego. Her research interests include workforce issues such as provider burnout and the delivery and financing of primary health care. Dr. Jabapur.
Thank you very much for that introduction. And thank you all for joining us today to go over the results of this very important report. Next slide. I wanted to give a special thanks to our contributors to the report. I'm presenting the results, but of course it was all these people on the screen that made this report possible. Next slide. So, like most of you, when I think of the healthcare response to COVID-19, these are the pictures that come to mind. Pictures of ambulances in front of ERs, inpatient teams in spacesuits taking care of critically ill patients. In fact, when you just Google COVID-19 and healthcare, these are the first images to appear. And when we turn the television on and listen to the physicians who are talking about their COVID-19 experiences, in general, it's our infectious disease specialists, our ER doctors, our intensivists. And while these providers are critically important for the acute care that is needed for the small percentage of infected individuals who need hospital level care, most of the COVID-19 pandemic is actually being treated like this. Next slide. So at home or in an outpatient office. In fact, although numbers change daily, state estimates show that between 80 to 90% of all confirmed COVID-19 positive patients will not need any form of inpatient hospital care and can be treated at home. And with the emergence of the vaccine and monoclonal antibody treatments, this is actually probably higher. Next slide. Those of us who work in primary care knew that we were a huge part of the COVID-19 response, but this wasn't maybe as apparent to most of the population. And really, we can't make a statement without having some data to back ourselves up. So our objective with this year's report was to do just that, to come up with the data to show that, and to examine what sort of an impact primary care had during the COVID response and recovery. Before we get to the analysis, I thought it was important to lay out our theoretical model. Besides working in primary care and with primary care providers, how were we so sure that primary care did matter during the pandemic response? To do that, we borrowed from a model that is used a lot when talking about the care-seeking behavior of a population in primary care, and that's called the Carr White boxes. For those of you who are not familiar with this, this is a visual representation of where and how people in a community seek care. So that big, darkest blue box you see on the screen there is the entirety of a population in a community before any disease is discovered. And primary care impacts this level through the provision of vaccination to prevent disease. And in fact, work done by us at the Robert Graham Center has shown that primary care offices are historically where the largest share of vaccinations are given. And work done by the AAFP and Kaiser Family Foundation show that even in the midst of this pandemic, where many primary care offices were not receiving the vaccine, the majority of patients during the COVID-19 pandemic were still dependent on their primary care offices in order to get information about the vaccine before they received it. In that next blue box, that's the percentage of population that gets some sort of symptom during any 1 month. And primary care is important there too. Our studies at the Graham Center have shown that traditionally, the primary care office is where most viral testing occurs. And then that next smaller box, that's when you do get symptoms and they're bad enough where you want to see your outpatient doctor for that. Again, from previous work we have done at the Graham Center, we know that when patients seek out care for their symptoms, it is primary care who traditionally treats their illness, particularly respiratory illness. We also know that primary care has the capacity to provide telehealth services. And during the pandemic, that's how many patients were receiving their care. And finally, let's say someone in a population does get hospitalized. That's the smallest, lightest blue box in the end there, the proportion of the population that will be hospitalized. And primary care impacts this level as well. As we know, primary care clinicians were being redeployed into emergency rooms and hospital settings at the height of the pandemic in many communities. And the reason this was happening was we were well suited for this. In fact, again, some previous research at the Graham Center has shown that a quarter of primary care physicians already worked in 2 or more settings prior to the pandemic. Next slide. So we know from that model that primary care had the capacity to make a huge difference in the response and recovery of COVID-19. But did we? We also know that with other diseases like diabetes, hypertension, obesity, it is not primary care alone, but a combination of primary care, public health, and social assets that makes a difference in patient outcomes. We wanted to determine if this was also the case for the COVID-19 pandemic. Did the combination of primary care, public health, and social assets make a difference in COVID-19 related outcomes? To do this, we created a novel index used for the first time here called the Community Health Index. And we used it to determine if there were associations at the county level between this index and publicly available COVID-19 outcomes. Our COVID-19 outcomes are on case incidence and death rates per 100,000 were derived from USA Facts and or the Johns Hopkins Coronavirus Resource Center, downloaded on April 15th, 2021. We downloaded the data on COVID-19 vaccinations from the Center for Disease Control and Prevention on April 21st, 2021, which was 2 days after the vaccine was made widely available to everyone 16 and older. We looked at cases and deaths before and after vaccinations were first available in the US, which was December 14th, 2020. Next slide. So I told you a bit about where we got our COVID-19 data, but what is the Community Health Index? I think it's important to spend a little bit of time here. The Community Health Index is a novel measure of primary care supply, public health preparedness, and social assets that was developed by the Robert Graham Center. We received primary care supply rates from the American Medical Association master file, public health preparedness scores from the National Health Security Preparedness Index. For social assets, or those components of at a community level that impact the health of patients, such as income, education, we use the American Communities Survey. This report is the first time that the CHI has been used in published research. Each component of the CHI was then given a score of 1 to 10, 1 being the worst in quotes score and 10 being the best score, for a total that ranged from 3 to 30. We then took those scores for each county and put the counties into 5 groups or quintiles based on their score from lowest to highest. 20% of the US population lives in the lowest CHI counties and 17% in the highest. The map here on the right shows the distribution of the scores by county, the lighter blue being the worst scores and the darkest blue being the best. Important to note here and going forward is this concept that in the top quintile, those with the best scores, the mean score was 27. This means that county had to have a high score in all 3 components to rank high. It could not be primary care alone that put them in the highest quintile. It could not be public health alone, and it could not be social assets alone. And the reverse is true for the lowest counties. Next slide. We then took publicly available vaccination data by county to see if these scores were associated with the percent of the population who was vaccinated. This data was adjusted for rurality and race. And you can see here on this graph, the x-axis is the difference in percent population that was vaccinated, and the y-axis is the CHI groups. It's kind of tricky because the lowest scoring groups are up top on the graph, and then the highest on the bottom on the y-axis. But it's easy to see that as the CHI increased, so as the scores got better, the percent of the population vaccinated also increased. So robust primary care, public health preparedness, and social assets did have an impact on vaccination rates. Next slide. We also looked at the COVID-19 cases on the left here and death rates on the right. The dark blue lines are before vaccination rollout started in the US, and the tealish line is after rollout started. So a few points that I want to make here. For every CHI level, once vaccination started, cases went down and so did deaths. So just in case anyone was wondering, it does seem like vaccinations worked for both. But it's not just having the vaccine available. There is something else that is happening here, because whether it was before or after vaccinations, counties with the CHI or the better score, the highest CHI, the better scores, had less cases and less deaths compared to those with the lowest scores. So it's the combination of good primary care access, robust public health preparedness, and social assets that also matters. And in fact, if you look closely here, after vaccination was made available widely, you were 12% less likely to get infected with COVID-19 and 42% less likely to die from the disease if you lived in those highest quintile counties compared to those who lived in the lowest quintile. Next slide. So this data is limited in that certain county level characteristics that may have impacted the findings could not be controlled for. Importantly, there was no control for testing rates in each county. It's possible that counties with higher COVID-19 case rates had higher testing rates. Yet, given that higher testing rates higher rates were found in counties with lower CHI and thus less access to primary care and less robust public health, it seems unlikely that these same counties would have higher testing rates. There are other obvious county level characteristics that could not be controlled for, like mask mandates, social distancing policies, and stay-at-home orders. But by the same token, it stands to reason that the public health components of the CHI that would have accounted for this as counties with stronger public health likely had these measures in place already. Furthermore, the analysis is at the ecological level and does not capture sub-county variations in COVID-19 outcomes. And similarly, there may have been individual level variables that were not controlled for due to data limitations. Yet we did control for most of the major factors that we already knew impacted COVID-19 outcomes, such as Black, Hispanic race, and rurality. And finally, we had to stop the analysis somewhere in order to produce the report. So we downloaded data up until April 19th, 2021. But as we all know, the virus and vaccination rates have continued to evolve from them. Also to note, and this isn't so much of a limitation as it is a consideration for future research, our data measured primary care, public health, and social assets separately and showed that all three components are important. But data emerging from Maryland and other states does show that the integration of public health and primary care was important in the response and recovery efforts around COVID-19. So it will be interesting to see future studies that examine the impact of a well-integrated system of public health and primary care. Next slide. So in conclusion, counties in the top quintile, which is 17% of our population, had high scores on primary care, public health, and social assets. And remember, it could not be one alone in order to be in that top quintile. Higher CHI is also associated with higher vaccination rates. COVID-19 case rates and death rates decreased after vaccination in every county, regardless of the CHI. But counties with the highest CHI had lower COVID-19 case rates and lower COVID-19 death rates than counties in the lowest CHI. Next slide. So what is our take-home message? I'll take us back to our title. Leveraging primary care, public health, and social assets was and likely continues to be essential to the response and recovery of COVID-19. Next slide. Thank you very much. If I don't get to answer your questions during the webinar, please feel free to email me, and I look forward to our panel.
Wow, thank you so much, Dr. Jabapur. That's important summary. I can't wait to get to the discussion, so let's get right to the panel. and some expert reaction to the findings from their perspective. So I'll introduce our panelists. The first is Dr. Seiji Hayashi, Chief Transformation Officer and Medical Director for Mary's Center, a community health center in Washington, D.C. that provides healthcare, family literacy, and social services to nearly 60,000 individuals whose needs too often go unmet by the public and private systems. Dr. Hayashi is an experienced leader in primary care, quality improvement, and health policy at the local and national levels. He has also worked at Unity Healthcare, another FQHC in Washington, D.C., as its Executive Vice President for Transformation and Innovation. Dr. Glenn Mays is the chair and a professor in the Department of Health Systems Management and Policy in the Colorado School of Public Health. He is also director of the National Systems for Action Research Program, which tests strategies for aligning delivery and financing systems for medical care, public health, and social services in ways that improve population health. Dr. Mays created and maintains the National Longitudinal Survey of Public Health Systems that has followed a nationally representative cohort of U.S. communities since 1998 to examine interorganizational and intergovernmental approaches to public health delivery and financing. He is also founding director of the National Public Health Practice-Based Research Networks program, which brings together more than 2,000 state and local public health organizations from across the U.S. to conduct applied research on innovations in public health practice. Next is Cincy Hernandez Cancio. She is the Vice President for Health Justice at the National Partnership for Women and Families. She previously served as the founding director of Families USA Center on Health Equity Action for System Transformation, where she led efforts to reduce disparities in healthcare outcomes and advance health equity. She has worked on building a thriving and vocal health equity movement to protect the gains of the Affordable Care Act and leverage healthcare and delivery system transformation to reduce disparities. And she served on the Addressing Disparities Advisory Panel for the Patient-Centered Outcomes Research and the Robert Wood Johnson Foundation's State Strategies Advisory Committee. Moderating our expert panel discussion today will be Ann Greiner, who is President and CEO of the Primary Care Collaborative. Earlier in her career, she served as Vice President of Public Affairs at the National Quality Forum and Deputy Director of the National Academies of Medicine and in the leadership positions at NCQA and the American Board of Internal Medicine. All right, Ann, over to you.
Thanks so much, Mark, for the introduction. And we really have a terrific panel here with us today to talk about the results and the implications of this report. Let me start by asking each of you, from your perspective as a primary care clinician, a public health expert, and a health equity advocate, what your overall reaction was to the report findings, including that those folks who are fortunate enough to live in the highest performing counties, the 17% of the American public, with the most robust primary care, the best public health infrastructure, and the fewer and the greatest social assets, were better able to stave off COVID effects. Let me start with Dr. Hayashi.
Thank you so much, Ann. And I'm a great supporter of PCC and all the great work that you guys do. So I really appreciate the opportunity to respond to this important report. So my first impression was that, thinking about the pandemic, 45 million people infected, right? And then almost 750,000 people dead. This is horrendous. And, we could have done so much more to save lives, but at the same time, it could have been worse. It's hard to imagine this pandemic being worse, but it could have. And if it weren't for so many people working hard, and we talk about the frontline workers, first responders, and obviously, healthcare workers, and we owe so many, for putting themselves and their families at risk. But we haven't heard a lot about the role of primary care during this pandemic, and I'm grateful this report highlights it. And within the context of public health and the impact of social determinants of health, like housing, food security, education and employment. So I'm really grateful for PCC and the Robert Graham Center. So providing primary care in these low resource communities is what we do, at Mary Center and other community health centers across the United States. This is what we do every single day. And as you heard, Mary Center serves nearly 60,000 individuals in the DC area. But I want to also highlight, it's not just any 60,000. We're talking about, our patients, 95% of our patients belong to racial or ethnic minority groups. Over 70% of our patients are best served in a language other than English. The vast majority are immigrants from Latin America and Africa. And almost all of our patients earn less than 200% of the federal poverty level. And that's, an annual income for an individual of less than $26,000 a year. So I hope it's obvious that, our patients have many barriers to care. And so throughout this pandemic, we've continued to, serve our patients. And as, Dr. Jabapur mentioned, telehealth and in person. And, from a personal perspective, I have many friends and, colleagues and even family members who work in the hospital, in the ER and the ICUs. And I tell them that my job as a primary care provider is to keep people from needing their help, keep people from, having to go to the emergency room and the hospitals and needing, ventilation. And so I like to show, this graph to illustrate, what that kind of means, right? This graph shows the percent of COVID tests that we've done and the percent, that were positive. So the red are the positives. And you can see, the red sort of mirrors the different surges that we had. And looking at the first surge in April and May, over 50%, especially in April, the tests were positive. And we conducted thousands of, COVID tests. And so just like, Dr. Jabapur mentioned, the Carr White model, the ecology of care, showed that we estimate that less than 5% of the patients who tested positive for COVID ended up in the hospital. And so the flip side of this, you might ask, what happened to the 95%? Well, the short of it is that we provided the care that they needed. And, we gave them medicines to help with their fever, cough, body aches, and we sent them home with, things like pulse oximeters to check their oxygenation at home. And we told them, call us if your oxygen level drops to below 92%. You might ask, why 92%? It's because the EMS in DC said they're not going to take anybody with a pulse ox, higher than 92% because the ERs and ICUs are overwhelmed. And so we counseled our patients to quarantine and get their families tested. Next slide, please. And just one more slide. So this is a map of where our patients came from to get tested. And I don't know if you can really tell, there's a diamond shape in the, small diamond shape in the middle, and that's Washington, D.C. And this is the D.C. metropolitan area that includes Northern Virginia, Montgomery County, Prince George's County, and you can actually even see Baltimore. And and the dark area in the middle is on the border of DC, Montgomery County, and Prince George's County. This is the area where many of our Latinx patients live and where we have 2 of our clinics. About half of our patients who live in that dark area are uninsured, but we care for them regardless. We provide COVID testing and care if they were sick. Even if they needed to be in the hospital, they often refused because they didn't want to be burdened with the bill afterwards. Some even refused to go to the hospital because they were worried that they were going to die in the hospital. They've seen and heard of family members and friends who went to the hospital and never came back. So you might ask, why would people come from so far away, knowing that there are actually testing sites much, much closer to their homes? They came because they trust us, right? And they tell their friends and families who live elsewhere also to come to Mary Center because they trust us. And that's the power of primary care, right? That's continuity of care. And then, really some of the magic that's necessary that we don't often see, in caring, for our patients. And the last point, I would just want to reiterate what Dr. Jabapur said. We provide care not only for COVID, but for everything else. People with high blood pressure, diabetes, heart disease, kidney disease, asthma, COPD, whatever it was, we did our best. And, the access to specialty care and hospital care was, very little, especially during the earlier, months. And many of them should have gone to the hospital, but, just similarly, they didn't, go. And so we did everything. And so the key point here is that primary care was a vital component of the pandemic response. And so, thanks for asking that question. I'll hand it back to you.
Terrific. Okay. Glenn, from your perspective, your reaction to the report results.
Yeah, really, really powerful findings again. Kudos to the Robert Graham Center and the Primary Care Collaborative for doing this great work. As a public health systems researcher, obviously we've been studying variation in public health delivery and financing across the country for decades now. And so we know that there are large disparities in public health capabilities across the country. And we know that those disparities result in and contribute to disparities in health outcomes. We typically see them over pretty long periods of time. Work that we've done has shown that, again, places with the strongest public health capacity across the country enjoy about a 10 to 12% reduction in preventable mortality over about 10 years compared to communities that have weaker public health systems. And similarly, we've shown that there are about a 2 to 3 year gain in life expectancy for people who live in communities with strong public health systems. But that's realized over a period of a decade or more. What this study shows us, a couple of things. One is the synergistic effects of having strong public health, primary care, and social infrastructure. And what's striking to me is that the magnitude of that difference, the fact that if you live in a place that is strong in all three of those sectors, really large differences in mortality, much larger differences in COVID mortality than we've estimated looking just at the public health system. And so that tells us that to understand the power of public health, you've got to also look at these other sectors that are strong partners in this work, primary care and the social services infrastructure. And so that magnitude of effect, the magnitude of the differences that we see in vaccination, infection rates, and especially mortality, really striking to me. Again, much larger than the magnitudes that we're seeing, that the magnitude of preventable mortality that we see by just looking at the public health sector. I guess the other thing that's striking to me is these are patterns that we've seen take place over a relatively short time frame. Certainly, when we study public health, usually we have to look at long-term effects of public health interventions because we're looking largely at preventing a disease and injury at the population level, and that takes time to accrue and time to observe it. I think the same is true for a lot of aspects of primary care and understanding the health effects. They really accrue over time. And also for our social infrastructure, what's striking here is that we can see pretty short-term, immediate, large effects from having all three sectors being strong together, being able to work as effective partners for each other.
Terrific. Thank you. And your point about the magnitude and the time frame, I think really want to underscore that. Cincy, your perspective as a health equity advocate.
Hi, good morning, everybody, and thank you for joining us to discuss this really important report by the PCC and the Grant Center. So as a health equity advocate, it's really fascinating to see a report that actually is putting together the synergies between social vulnerability, primary care, and public health. That is a really interesting way to look at how what we all know, which is that the outcomes in healthcare are not just driven by the healthcare you get, not just driven by the public health infrastructure that there is, and not just driven by social drivers, but that there is a combination of those factors that really produce whether someone has good health, medium health, or high levels of health. And so from a health equity perspective, it's really interesting also to see that because the the model was really trying to control for other factors, individual factors and other community factors, such as the prevalence of people of different races and ethnicities, and also rurality, that as we're thinking about the impact of this information, I invite you all to consider that what those maps would look like if we had not controlled for being a person of color in this country, and or living in a rural area, because we all know, and we see this in the, we're seeing this in the newspapers, daily, that if you were a Black person or a Latinx person, you are much more likely to be exposed, contract, and die from COVID. And similarly, and we're seeing this right now, how much more prevalent and deadly COVID right now is in rural areas. So that, in terms, since what I focus on is advocacy, I think that combining the information that we're seeing in this analysis with also what we know about what the actual communities on the ground in the lowest quintiles look like, I think it should really light a fire under people about how important it is, given what we know about those three categories of factors that affect a person and a community's health, that as we are reinvesting and building back our healthcare system post-COVID, we have to center primary care, rebalancing towards more primary care. We have to invest much more significantly in public health, and especially in systems of care like Mary Center that are not dependent on people having insurance, because that, as we've made great strides in insurance coverage for folks in the last 10 years, but there's still significant parts of the population that don't have insurance. And so having a strong community health center, and public health infrastructure is going to be really important, especially in these, the lowest quintiles of what we saw in outcomes. And then also that it's way past time for us to invest in addressing the social drivers of health. And this index that was used includes a few of them, but there are many, many more. And let's not forget that one of the biggest social drivers of health is the experience of being a person of color in this country, because of the structural inequities and structural racism that continue to exist, which in this country are very geographically concentrated, right? Our history of segregation, and we're currently still as segregated now by race and ethnicity as we were 50 years ago. So when we see these zip codes maps, we also have to understand that what if we scratch under the surface of those zip codes, we're also seeing certain concentrations of different racial and ethnic communities. So I think that this is an important report to be able to use for advocacy towards building healthcare, the ecology of the healthcare and the health systems that our country needs to be able to not only recover and get through the COVID pandemic, but to really create the high functioning healthcare system that can encourage and promote high functioning, healthy, thriving communities, so that we can all prosper together.
Thanks so much, Cincy. And I think all of you have underscored the importance of looking at examining these issues at the zip code, or in this report at the county level, to try to understand what's occurring. Because when you roll it up to a state, so much washes out. You're really not able to understand these differences. And so I think that also suggests the importance of this county level analysis. So I think one thing that Yalda said and all of you reinforced is this importance of these three factors, and we don't see a lot of reports that bring them all together. We also think that there's a lot more work to do to look at this interaction between these factors. And there's beginning to be some research that does that. But I'm wondering if you all, and whoever wants to jump in first, would reflect on what is your view about how primary care, public health, and community-based organizations that are trying to address some of these social determinants are working together, and what effect COVID-19 may have already be having on those interactions, you know, through better coordination, communication, et cetera. So who would like to take a, please go right ahead, Cincy.
Yeah, I'd like to give sort of a few examples of how that worked, and it was mentioned already that Maryland is showing some successes, and we do you know, work in Maryland as well as in DC, and I think many people may not realize what's necessary for testing to occur or, you know, vaccinations to happen. Somebody actually has to give that shot. Somebody actually has to, like, you know, do that swab, right? Who are they? And, you know, and then you also have to think about, like, where do the resources come from? And as a federally qualified community health center, you know, we get resources from the federal government, you know, like HRSA and CDC, and they need us because we're the people on the ground. We are doing the testing, we are doing the vaccination, and then all the jurisdictions in between. I've never seen so much collaboration among state, you know, federal, county, and local jurisdictions like this before. Obviously, it was a necessity, but it was amazing. Within days, the state of Maryland sent us, you know, dozens and dozens of National Guardsmen to help us with the vaccination efforts. And the DC Health Department, you know, they reached out to us very early on to make sure that, you know, we were having the same the resources necessary to, you know, care for our communities. And, you know, DC Medicaid, for example, they, the policy level at the state level, you know, reimbursement for telehealth, that was crucial. You know, DC was one of the first to authorize it, and looking at some of my colleagues in other states where the policies to reimburse, you know, primary care for telehealth was delayed, some of the business community health centers and primary care practices were in dire financial straits. But so, you know, just thinking about all the, you know, collaboration that was necessary, I'm just excited about, you know, what occurred, and I just hope that we never go back to the way we were doing right after the pandemic.
Thank you. Great to hear about silver lining with the pandemic. Go ahead, Cincy.
Yeah, I want to reinforce that it's crucial that we do not go backwards, right? A lot of people have this instinct of saying we want to go back to normal, but the normal in the status quo before this was actually not a very good status quo. And there were many people in many communities that were suffering deeply, and there were also, you know, many barriers to improving access to and the quality and trust in healthcare that were in place that we have now figured how to get around. The other piece that I really want to highlight is that Sage did a great job of talking about, like, what is needed for people to get their shot and for people to get tested. And from the provider perspective, but I think it's also really important to figure out, to talk about what's needed from the patient and the community perspective for that to happen. And that really happens at the pace of trust, which is why it's so important not only to support Mary Center and other federally qualified health centers, but to really learn from what those providers are doing and have been doing for decades, where they are trusted. You saw those maps of how far away people would go to be able to get to a Mary Center, and consider that these are folks who, many of whom don't have their own car, have to go through, you know, find a friend or somebody to take them, or take public transportation. Other barriers that were really critical for these communities was, what are they going to do with their kids because schools were closed? Those who were able to keep their jobs certainly could not take time off to go to the doctor, or, to get tested or get their shot, because paid leave so far, and let's cross our fingers that the Congress fixes this shortly. Paid leave is not something that's guaranteed for folks, and certainly not for the low income, frontline workers that many of these communities, where many of these communities work. So it's really important that as we build back, we take advantage of investing in some of not only the FQHCs and those kinds of community clinics, but also in the nonprofits that have the health, the promotoras and the community health workers and the folks that really already have the trust of these, supposedly hard to reach communities, and that those partnerships not only are strengthened and continue, but new ones are sought out, and that these partnerships are well funded, because lots of these small community-based organizations were so hollowed out by the crisis. Many have had to shut down, or because there hasn't been the kind of support for that work that really is needed for all of us to be able to thrive together.
Thanks, Cincy. Glenn, anything to add?
Yeah, just to underscore a few things, that community engagement piece that Cincy just mentioned is really pivotal, and that's especially what we found in our work in looking at the public health system, how important it is to coordinate community engagement strategies across these different sectors. There's an adage in the emergency preparedness world that the disaster is not the time where you want to be exchanging business cards or getting to know your partners for the first time. And I think part of what's reflected in the data is that places that already had these strong relationships in place between public health, primary care, and that full array of community-based organizations, those places were able to leverage those partnerships and stand them up and target them around the new work around testing and vaccination and just communicating the importance of COVID mitigation strategies. And another thing that we've seen in our data, places that didn't have a lot of that pre-existing community engagement capacity, there were bottlenecks, and there were places where community-based organizations were really being challenged to respond to multiple agencies coming to them with requests for information and assistance, public health coming to them separately from primary care or from other sectors, and that kind of dynamic can really overwhelm the limited capacity of our community-based organizations. So again, already having a collaborative community engaged structure for responding to community health needs, a real advantage in this situation.
Terrific. Well, thanks so much. And we've got questions coming in through the chat. Let me invite Yalda and Mark back, and we'll tee up some additional questions for this group. One that's come through is, we know we've been chronically underinvesting in primary care and in public health. Maybe this is a less cheery subject, and it is, I recognize, somewhat speculative, and appreciate the person who wrote in. What might have been different if we had the kind of investment in public health and primary care that we need? Anybody want to take that question?
A few thoughts. Please go ahead.
I guess I'll just start with the obvious one, and that's that there would have been a lot less pain and suffering, a lot fewer shortened lives, less of an economic crisis and hollowing out of our labor force early on in the pandemic. I mean, I don't want to say necessarily that primary care is a magic bullet, but it kind of is like that when it comes to making sure that we have the infrastructure that's needed to support whole person, whole community health. And part of that is not just that, my dad was a family physician, they're like the Swiss Army knife of doctors, right? They can do many, many things. But more than that, there is continuity. There is a building of trust. Just like there were people coming from 2 counties away to Mary Center, for my dad, people would come across state lines, 40 minutes away, an hour away, because there was a Puerto Rican doctor who spoke Spanish, who understood them, who they could trust, that they would not be mistreated or treated or dismissed. And so that is where that happens in primary care. And that's why we need to invest a lot more into the primary care workforce and structures.
Glenn, I think you were, thanks, Cincy. I think you also wanted to jump in on that question.
Yeah, I think about the underfunding of both our really primary care, public health, and our social services infrastructure. I mean, one of the consequences of that is, 1 in 5 Americans, residents in this country, don't have a usual source of care. So they're not connected to the healthcare system. So that right there put us behind the 8 ball in terms of being able to reach out to the full array of populations that needed to initially just to get the messaging about the risks and what they could do, to mitigate them, long before we even had a valid test, and certainly long before we had vaccines that worked. So we could have hit the ground running much quicker if our systems, these 3 sectors, already had more of that connected tissue to coordinate our messaging, coordinate our outreach strategy, and to really marshal the full array of community resources to reach those organizations. We had more of that connected tissue in that top quintile of communities, and that's why I think we see the patterns we do. But in vast swaths of the rest of the country, we had to figure out how to build that connective tissue while all these sectors were under the gun. In that we paid the price in that in human terms.
And I think from the perspective, we can talk about advocacy for a moment here too, because the connectedness between the financing systems for public health, or the financing of primary care, or the financing of social services, and the connection to the political will and social context for those sectors is also connected. So when you underfinance primary care and you underfinance public health, and then you put the whole system under stress, no one can be surprised when it becomes politicized and terrible for the people who work in it, right? So we know that primary care collapses immediately when the fee-for-service system is no longer relevant in the beginning of a pandemic. The same is true for an underfunded public health system. So I think the public policy piece of this is important in terms of appropriations and financing as the actual policy of how we do medical care and how we do public health in the country. I think you can't untangle those 2 concepts.
Terrific. Thanks, Mark. This is a great question. Someone asked, who's responsible for collaboration between these sectors, and how could that happen, and what would the costs be? Go ahead.
I think it's incumbent on all of us to, be partners. And like Cincy said, and what Glenn said, the system, the communication channels have to be open beforehand, or before a pandemic or an emergency occurs, for it to go well. And at Mary Center, we have a lot of people reaching out to us because we're a trusted, organization in the community. But sometimes our resources are limited, and we have to sometimes say no, right? But when it comes, time to really step up, we were there. Similarly, when I can pick up the phone or text, people at the Department of Health and say, "Hey, we need this help." And they're going to pick up the phone, they're going to respond to my emails and whatnot because we have that communication, and we need more of that. We need more personal sort of understanding and communication, so that when hard policy decisions and restricted resources are on the table, we can really work together and prioritize where we go. And an example was DC Health, in terms of allowing vaccination, sign up on their portal. They focused on certain neighborhoods and prioritized, vaccine appointments in these neighborhoods. And that would not have happened if there wasn't enough communication. And the community-based organization, like Cincy said, it's the community-based organizations, some of the faith-based organizations, some of the community health centers. We all kind of work together to make sure that people got onto the website and the portal, and then allow the DC Health to actually do their things that they needed to do. And so it's we need to build it before it happens, and I hope that we don't let this infrastructure that were developed during the past 2 years to go to waste.
Yeah, Yalda.
Yeah, I mean, I think to build upon what Seiji was saying too, build it before it happens. And I think Seiji and I are somewhat lucky in that we both work clinically in DC, and DC did relatively well during the pandemic. I think Seiji has shared with you, all the ways that DC and Maryland were prepared. And I know that before this pandemic, before COVID-19, there was already some integration. The DC Department of Health was not a stranger to me as a clinician. We had already been working with them on things like HIV testing for the high rates of HIV in certain districts and in certain areas of DC. And so I think building it before you need it is important. And I don't know that there is one person in charge of doing that, and this needs to be done at a local level, but build it before you need it. I think that's a lesson to be learned here.
I know from talking to folks around the country, particularly, back in the spring of 2020, that in some states, and states you might be surprised about, public health did not even know where the primary care practices were located in a given state, let alone have any way to communicate with them directly. And so they were having to go to major health plans and say, please help us identify so we can, open up channels of communication, start letting folks know about, the data that we have to communicate and let them know about the construct in which they're practicing. So clearly, lots of differences across the country. Not sure I got an answer to, though, who should drive this integration, who's responsible for it, and okay, Cincy.
So I think there are a couple of factors there, and you really have hit the nail on the head that there needs to be somebody who can bring together all the pieces and bring it together in ways that are not just responding to like market forces, but what actually is needed for a given community. So I believe that state leadership is extremely, extremely important. And part of that is because they can set the infrastructure. They are able to step back 30,000 feet view of where things are. And leadership matters. Leadership absolutely matters. And so that's point number one. The other point I think is important to make is that when you get to the micro level of communities, it's incumbent on the provider and the public health system to reach out to the nonprofits, to the community-based organizations. Community-based organizations, the ones who actually have the trust and understanding and language capacity and understand how to navigate all of the barriers that the community that they work in are facing, do not have like extra time, headspace, money to figure out, I'm going to go walk into X health center or X hospital or, the public health office to figure out like what I can do, right? The ones who have more resources and more understanding are the ones that need to affirmatively, when it's not a crisis, be stepping out and connecting with the community-based organizations on the ground, and not just for communication, but understand that they need resources as well. And so creating, memorandum of understanding and providing grants and all of that so that there can be more seamlessness in that communication and that coordination both ways is going to be essential. And so I think that those two things are extremely important and central, I think, to the local community-based landscape are these FQHCs and community health centers, because guess what? One of the reasons they're so good at what they do is because they actually have leadership boards that are, 50% at least have to be people from the community. So imagine, what a coincidence, right? That then they're better at actually addressing the needs of the community. That is not what we see in hospitals. That is not what we see in insurance companies. That is not what we see in the private sector. So there's a lot that we can learn from organizations like the one Seiji works in.
Thank you so much. And please join me in thanking this terrific panel, and to Mark Del Monte for, really hosting this event. Back to you, Mark. We are, I know, out of time.
Yes, I wish we weren't. I wish we had another hour, and this has been a very exciting conversation. Thank you to our panelists. Amazing. And, to answer your last question more directly too, one of the things that is important to do is join organizations like the Primary Care Collaborative, because it's going to be a collaborative approach that's going to get us across these connections and to build primary care in coordination with public health. So download the report. It's good reading. Thank you, everybody, for joining us today, and have a great rest of your day.